let's take our discussion forward to a very new segment or a very new topic of macrocytic anemia. So basically what I told you, whenever a patient is coming to your OPD with any such error in your CBC, the first thing which you have to check is whether it is a single lineage issue or whether it is a tri-lineage issue. Now, if it is a single lineage issue, then there will be errors or there will be distortion with RBC count or WBC count or platelet count, right? Now, it's a tri-lineage issue, then there will be a problem regarding all the three values will be distorted, and that will be a presentation of pancytopenia. But now, for the time being, we are just focusing on RBC. So, if a patient is coming to the clinic with a decrease in the RBC count, decrease in RBC value, then we will be classifying it as a single lineage issue. And the next thing what we are going to do is we are going to calculate the reticular production index. Reticulocyte production index you are going to calculate. If the reticular production index is what? Less than 2.5. It is less than 2.5. Then we will be classifying it as hypoproliferative anemia. And now, after getting it as hypoproliferative anemia, you have to check the mean corpuscular volume. Mean corpuscular volume. 80 to 100 femtoliter is the normal mean corpuscular volume value. Now what happens? If it is less than 80, you will be saying it as what? It is microcytic. 80 to 100, you will be calling it as normocytic. And greater than 100, you will be calling it as macrocytic. So, if it is a macrocytic cause, then what are the clinical presentations you are going to get? What are the different symptoms you are going to get? Or what are the different causes for this? That we are looking into the chapter of macrocytic anemia. So, let's all focus our complete attention towards macrocytic anemia. Now, this is what is macrocytic anemia. MCV is greater than 100 femtoliter. Then we will be classifying it as macrocytic anemia. Now, basically what I have to teach you over here is macrocyte is not always megaloblastic anemia. You have to please keep this in mind. Macrocytic anemia is of two types. Megaloblastic macrocytosis and non-megaloblastic macrocytosis. Focus your attention on. Megaloblastic macrocytosis means, macrocyte means what? There is what? Big RBC. RBC size is increased. That is what is macrocyte. That is MCV is greater than 100 femtoliter. That is the case of what? That is case of macrocytosis. That doesn't mean it is their megaloblastic macrocytosis. Macrocytes can occur in a large amount of cases, but it is not always megaloblastic in nature. Now, what is megaloblastic macrocyte? You all know that your RBC, I explained you the erythropoiesis pathway. In erythropoietic pathway, you can see that while the RBC go down the group, we can see each precursor, like pro-normoblast, early normoblast, late normoblast, each while moving down the group, you can see that the size of the RBC precursor is actually decreasing. It is very much decreased. And what we can see, reticulocyte, in the base of reticulocyte, the nucleus is completely extruded. It is completely pushed outward. Nucleus is pycnotic in nature. Right? It is pushed out of the cell. Right? Now, your mature RBC is not having nucleus, it is not having any sort of Golgi apparatus, no mitochondria, no cell organelles in fact. It is very much a pure cell without a nucleus or cell organelle. That is what is your mature RBC. But if you take the precursors like pro-normoblast, early normoblast, late normoblast, everything is having nucleus is there. Cytoplasm is very large, but you will be having a very large nucleus. But RBC, while moving down, you can see that the size of the nucleus is small and it is shrinking, and you can always see that the size of the cytoplasm is actually increasing. Right? This is what is the main concept. And what happens here is you will be having a nuclear cytoplasmic asynchrony is what is happening in megaloblastic macrocytosis. So, nuclear cytoplasmic asynchrony, which means that I told you why in the group, if you are checking the pro-normoblast or early normoblast, it is having mitosis, but moving down, you are not having any mitosis. RBC, there is no mitosis is present. So here, what actually happens is condensation of chromatin. Condensation of chromatin is actually lagging behind, or it is not happening, and that is what is called megaloblastic macrocytosis. That is what is called megaloblastic macrocytosis. But in non-megaloblastic macrocytosis, there is what? There is proper nuclear cytoplasmic maturation is happening. But what is actually happening here? RBC size just increases. RBC size increases. That is only happening. There is no nuclear cytoplasmic asynchrony that is absent in non-megaloblastic macrocytosis. Clear? Now, macrocytic anemia, which means RBC size increase plus megaloblastic changes. Megaloblastic changes means what? Megaloblastic changes means there is nuclear cytoplasmic asynchrony is present. Then that is what is called what? Megaloblastic anemia. That is what is called megaloblastic anemia. So, in megaloblastic anemia, you will be having large RBC whose mean corpuscular volume is greater than 100 femtoliters, plus the RBCs will be having what? Nuclear cytoplasmic asynchrony. And what are the different cases of that? Vitamin B12 deficiency, folic acid deficiency. It can be due to some drugs like citrabin, hydroxyurea, and a very famous drug, 6-mercaptopurine. 6-mercaptopurine, which is an anti-cancer agent. It is also causing what? Macrocytic anemia plus megaloblastic changes, which will be causing megaloblastic anemia. And thiamine deficiency, porotic aciduria, all these 5 causes will be causing what? Megaloblastic anemia, which means there will be macrocyte plus nuclear cytoplasmic asynchrony. Now, there are cases where non-megaloblastic macrocytosis is happening. That means macrocytic RBCs or macrocytes can be seen, but there is no megaloblastic changes, no nuclear cytoplasmic asynchrony is seen. And that cases, bone marrow failure syndromes like myelodysplastic syndrome, and then you will be having a very famous case of aplastic anemia. MDS is the single most reason of what? Macrocytosis plus non-megaloblastic changes. And here in MDS you can see macroovalocyte can be seen in MDS. In aplastic anemia also macrocytic anemia is there, but there is no megaloblastic changes. And liver diseases, scurvy is due to vitamin C deficiency. You will be having bleeding gums. That case also you can see macrocytic RBC, but there is no nuclear cytoplasmic asynchrony. Then hypothyroidism, you can see there macrocytic anemia, but there is no nuclear cytoplasmic asynchrony. Alcohol consumption, reticulocytosis, post-bleeding, and very important is COPD. In COPD patients, you can see macrocytes, but there is no nuclear cytoplasmic asynchrony, which is very important. So I think you all must have understood the basic idea of what is a macrocyte and how it is different from megaloblastic changes, and what are the cases where megaloblastic changes plus macrocytes are present, and what are the cases where macrocytes are present where megaloblastic changes are present. So I think you all must have understood what I taught in the video. So in the next part, we will be discussing about the vitamin B12 deficiency and also the folate deficiency causes and megaloblastic anemia in detail. So stay tuned with my channel. Thank you guys.